Hello, volunteers, and welcome to our 2014 volunteer training. Thank you for taking a little bit of time to look over our presentation that we gave the end of June in person at St. Anthony's. We're just going to be going over a couple of important policy and procedure items and get everyone up to date on what we're doing going forward for fiscal year 2020. So we started our live training with a little bit of an icebreaker, something fun to think about for a moment on your free time of what you would like to be remembered for when you're reminiscing about life in your old age. Very appropriate for our clients, of course. And I'm going to go ahead and jump right into talking about HIPAA. So for most of our volunteers that are in the medical field know, HIPAA is the Health Insurance Portability and Accountability Act, which is basically how we keep our clients' privacy intact. It's very important that we do this in the most conscientious way since we are a traveling clinic. There are certain opportunities for patient information to be exploited or to be inadvertently compromised. So we just want to make sure that we are all on the same page with the updates in HIPAA, and we are all taking as much care as possible with our clients' information. So protected health information is what is covered under HIPAA, and it's basically anything that can identify a client. This whole entire list: addresses, names, account numbers, insurance plan numbers, everything that's in our client's chart can be pretty much be considered PHI and needs to be protected. And one way that is often the ability of folks to have their data compromised at clinic is if another client is perhaps looking over someone's shoulder or nudging in on a conversation, or if you have to get up and ask someone a question. Don't leave someone's chart lying open where anyone else can see it. So HIPAA does allow for us to speak with other organizations, medical facilities, each other about treatment, payment, or operations. These are all things that are covered. Our privacy, the client's rights and responsibilities, and our release of information that we have our clients sign. And when we do have our clients sign this, we tell them that we won't disclose their information to a doctor or whoever without getting a verbal okay from them first. Them signing this doesn't just give us the willy-nilly ability to talk to anyone no matter what at any time. If you have any other questions about HIPAA or want some detailed information, please feel free to contact me or Dan, or look into it yourself online. It's really pretty simple. It's just treating others' information the way you want to be treated. And on that note as well, we're also going to be talking about mandatory elder abuse reporting. So the law has changed, and certain professionals and volunteers must report abuse, caretaker neglect, and exploitation of at-risk elders age 70 and over. So that is many of our clients, and we would like to extend our mandatory abuse reporting to cover all of our clients regardless of age. That's our policy. So abuse occurs when obviously someone has been caused harm to another elder. Some of the indicators that you might see in clinic are repeated ER visits, bruises or injuries in various stages of healing, unconvincing explanations of injuries, And this does include any signs of sexual abuse as well. That's covered under the abuse statute. Caretaker neglect can be many different things. So who is a caretaker? A person who is paid or unpaid and has assumed responsibility for the care of the elder. It can be a family member, a home health provider, facility staff, or even a neighbor who has formally agreed to provide recurring assistance. We are not caretakers. A neighbor who randomly pops in from time to time to check on or help out a client is not a caretaker. And the law is very direct in saying that some of the things that are not caretaker neglect, which I think we know, but need to be outlined, is advanced directives, hospice care, or living wills, anything like that that is maybe helping a patient plan for a comfortable end-of-life care or anything like that. That is not neglect if they don't want to be resuscitated or something else like that. Exploitation is one that you actually may run into in our clinics more so than the other two. Anyone associated with the client that is using the elder's assets for their own personal gain or do not use the elder's assets to secure their basic needs and care can be exploiting one of our clients. So maybe the nephew lives with them or gets their social security check and then doesn't give them all that money. Or maybe the neighbor is charging an exorbitant fee to drive our client to go get their medication because they have no other option to get there. So just be aware of those things. Many times the person who is committing the abuse on the elder is a loved one or a friend. So you need to be sensitive of the fact that the client might not want to implicate them or get them in trouble. But anytime you see something that might be a red flag, you want to come and talk to us. So you are a mandatory reporter. Even though you're just a volunteer, you are covered by this statute. So it's really important to make sure that you are aware of this law and that you are comfortable with it. So this is how you make a report. Basically what we want you to do is the minute that you suspect something, you need to pull in our clinical coordinator, Dan, preferably during the conversation so that Dan or another staff member can act as a witness. A witness must make a report, but if there's two witnesses, they don't both have to make the report. So that absolves you of the responsibility of having to be the one to make the report, which we are obviously happy to do. So anytime you see something, grab a staff member, preferably our clinical coordinator, and bring them in on the conversation. If you knowingly make a false report or willfully fail to report it, it's a class 3 misdemeanor. But it's fine to report if you just suspect something is wrong as long as it's done in good faith. Yeah, you don't have to 100% know for sure they're being abused. As long as you just suspect something, it's fine. Now, one thing that we didn't yet cover is self-neglect, which is not considered abuse under this law. But we obviously have many clients that maybe fall into self-neglect. So we definitely want to try to work with them and taking better care of themselves and being more activated in their health. And maybe sometimes calling Adult Protective Services is the most appropriate step for us when a person is doing that. However, be warned that APS is always going to take the least invasive route of working with our clients. So they always have the right to refuse services no matter how dangerous it seems to us. So if they don't want to bathe, if they don't want to clean up, their apartment. If they don't want to take their medicine, we cannot force them to, and neither can APS. So that's a really important note, which can be difficult to overcome sometimes. And that's why, though, we work so closely with our clients and try to hold their hand and bring them along to hopefully become more activated and not so self-abusive. Next, Dan will start talking about some of the clinic protocols that are changing and some of the specifics on forms and other such things like that.
Thank you, Lori. So this is Dan, clinical coordinator and lead clinic nurse with HealthSET's Health Promotion Clinics. Just wanted to touch base about some new forms that we have, some updates to our clinics, and some new things you'll be seeing, and just some refreshers on some things we've been doing this past year. So first is our new intake face sheet. We have a new sheet, and I'll click slide so that page 1 of our new face sheet, it looks pretty similar as far as the top goes. There'll be a few new items that you'll want to make yourselves familiar with when you get out to the next clinic. The highlights are, we tried to make it a little more user-friendly as far as having some areas with, like you'll see on the health system, we have options there from Centura to Denver Health to Kaiser, Exempla, University, InnovAge, VA, Senior Care of Colorado, Health One. So as you come across clients, if that's left blank, you can figure out where their primary care provider is and what health system they commonly use. We track that for our purposes so that we know what percentage of each building is using what health system. And that's particularly important because Centura Health sponsors HealthSET's clinics, and Centura Health wants us to, has charged us with making sure we're utilizing Centura whenever possible. So you'll start to notice that as well, that we'll want to utilize Centura Health primary care providers, and if there's a client that needs a new doctor or new insurance or new health system, we may refer them that way. And then if there's not a convenient option with the Centura system, then by all means we'll utilize Denver Health or Kaiser, whoever's convenient in that neighborhood where a clinic's being held. Another change to the face sheet in the chart will be our functional assessment, which you'll see down on the bottom left-hand corner of this page. And it has a 6-question activities of daily living survey to see if somebody's frail or not. And frailty status is one of our grant reports that we track the percentage of our clients that are frail. So if people answer no to 2 things on the activities of daily living, then that deems them frail. And some of the other highlights you'll just get to used to as we start using this chart. Page 2 and 3 are listed here. So page 2 has a health history and diagnosis list. We're trying to roll this out. We'll be using this on all new clients starting July 1st. So by now we'll be using this. You'll start to see this on all our new clients. And we will develop a plan that is based on our staffing at each clinic. If we have enough help, we may start to roll this new face sheet out for existing clients that already have a chart with us, and just get an updated health history and symptom and complaint list. As these things come up, we can update that on page 3 there. So the way this works, I'm envisioning the health history and diagnosis list to be filled out right away on either visit 1 or visit 2. And then whenever there's a new diagnosis, obviously we can update it. And it has as you can see on the columns, there's a year of onset and then whether or not the client feels that that diagnosis is being managed. And if not, when we ask them to follow up with their primary care provider. And we can help clients get an appointment if they need to, if they feel something's not managed or if they're having a complaint or a new symptom that we need to have the doctor address. So by all means, check our forms box when you get out to the next clinic, pull out a new chart, and feel free to look it over and familiarize yourself with these new forms, and let me know if you have any questions as you start to see these in charts. Lastly, on page 3, the commonly used protocols are down in the bottom right-hand corner there of this slide. And those are just protocols around the different stages of blood pressure that we might see, different stages of oxygen saturation, and heart rate or pulse that we might see in clinic. So when in doubt, if you have an abnormal vital sign that you come across with a client, always pull me or Janet, one of our other staff nurses, in to the conversation, and we can deal with that appropriately before the client leaves clinic. So on the vital signs flow sheet, as we've been using, the flow sheet is where we put all our vitals and then the questions about when they last saw their doctor, if they've been hospitalized, or if they've fallen. A lot of our clinical outcomes and grant reports require us to provide our clients with better access to their primary care provider, reduce hospitalization, readmissions, and reduce falls. So that is why those are on there. We're not just asking them just to bug the client every month with the same questions. So with the primary care provider visit question, if somebody hasn't been to the doctor in some time, typically over a year is when we want to get involved. But if somebody hasn't seen their doctor and say one of the options is 7 to 12 months, if they answer that question with that answer, then we can also intervene. And by all means, pull the client advocates in who are on hand at our clinics, pull them in to help the client schedule an appointment if they're having trouble calling their doctor, because sometimes giving a phone call to the doctor and scheduling the appointments can be quite a hassle and be on hold for a long time, and they get fed up and then just give up on it. So we want to empower them and activate them to see their doctor regularly. If somebody's been hospitalized, pull a post-hospital questionnaire out of our forms box, which is on hand at every clinic, and fill that out. If you have questions on where that is or how that questionnaire should be filled out and you haven't done one before, definitely grab me or Janet again, and we can walk through that with a client next time you come across a hospitalization. We want to reduce readmissions, so if we can catch people that have been hospitalized in the last month, we're hoping that we can connect them with appropriate levels of care, make sure they're following up with their doctor, make sure they're taking their meds correctly, and make sure they understand any red flags that they have with their new diagnoses. Any falls since they last saw us, if somebody has reported a fall, delve into what happened, record that in your progress note, some information about the fall, and review the fall prevention handouts that we have on hand at clinic. Again, check our forms box, make sure you know where the fall prevention handouts are. We have a fair amount of clients that do report falls. Since we started asking that question, we've had about 175 falls reported across the last 12 months. So it's not a huge percentage, but it's definitely something that we can impact and discuss fall prevention. And reducing clutter in their homes, making sure they're wearing good shoes, safe footwear to prevent tripping over their shoes, using walkers, canes, or wheelchairs if appropriate, etc. So just review that fall prevention handout with clients every time that happens. And if they refuse that, that's okay. You can just document that on the vital signs flow sheet. So fall prevention, just a little background on that. Like I said, some of these are in our grant reports. As you can see there, 1 out of 3 adults falls each year, but only about half talk to their healthcare providers about it. Since HealthSET is kind of a trusted, dependable healthcare provider in these apartment buildings, many clients turn to us to report things that sometimes they're not even comfortable talking to their doctor about. So if you do come across a fall, that might be one thing you discuss is if they've spoken with their provider about that, to discuss if there's any options around their physical health that could be exacerbating their fall risk. As you can see, just there are some other statistics on the cost of falls. In 2010, according to the CDC, was $30 billion, and there's the 16% of our new clients across the last year reported a fall. So it's definitely an issue with a decent amount of our clients in a significant spot where we can make an impact. So this just is a quick glimpse, screenshot of our fall prevention handout, the 6 tips that you'll see on our form when you pull that out at clinic. So you can pause that slide if need be and look that over to see the 6 tips that we commonly discuss. Next is the post-hospital questionnaire, which I mentioned a couple slides ago. But the educational handouts that we have for the big 6 common conditions are listed there. Those are based off the 6 conditions that commonly cause readmission. So we want to touch on those if somebody has been hospitalized with a new diagnosis of any of those 6. In our forms box, you'll find handouts that goes into a little more detail so that the client can get a better grasp of what happened at their hospitalization. Next, Allison Mercier is our client advocate coordinator, and she designed this program pretty much from scratch last summer. And so we've kind of taken it from the ground up, and this is our initial glimpse of the data after a year. And based on 579 client needs that were identified from the needs assessment, the most common all the way to the least common. So you can see dental, vision, and accessing their medical home or primary care provider, and end-of-life care planning, like advanced directives, living wills are kind of the top 4 there. And then it trickles on down, and you can kind of see how many needs have been reported to our client advocates. So the client advocate's role at clinic, and just so everyone is aware, we will be filling the gap in the client advocates. Our Allison Mercier, who I mentioned, is leaving HealthSET. She got into med school and will be leaving for the University of Vermont in mid-July. So there will be a gap there where we will be hiring a replacement for Allison. And then we'll also be getting another Colorado Vincentian volunteer, full-time volunteer, that will be doing a similar role to what Kirsty Clavercamp was doing for us. And we will have the Colorado Vincentian volunteer starting in mid-August. So she'll be starting as a client advocate at that time. But from mid-July to mid-August, there may be a gap in having a client advocate on hand. So if that happens, just pull me aside if there's a question about any of those things around dental or vision, hearing aids, benefits questions, how they can best get connected to their doctor if they need a new doctor. When in doubt, pull me aside or chart something in your progress note and confirm the client's phone number so that we can follow up with them by phone with some information and assistance to help them. That is appropriate. We go over every chart and read through all the progress notes after clinic so we can catch that within a day or two and then follow up with the clients as needed. So the orange and green stickers, I'll explain that. On the front of the paper chart at clinic, each client, if they have an orange sticker, it means they had the client advocacy needs assessment done in fiscal year 14. So that was from last June until July, or last July 1st until June 30th of 2014. So our fiscal year just ended. So if they had a needs assessment in that year, it would be an orange sticker. If there is a green sticker, it means they've had a needs assessment this fiscal year, starting July 1st until now, until present. So that will be an ongoing policy that we use. So if you see a sticker on the front of the chart, orange or green, it means they've had a needs assessment. If there's no sticker there, it may mean that there wasn't a needs assessment done yet. So once a client advocate is present at clinic, we can refer those clients over to the client advocate. If they need any follow-up, that would be noted with a sticky note on the chart. So when you're doing the vital signs entry, you'll see a sticky note with something like that says follow up on their dental care or check in about the client's last doctor appointment. So just check that, and then you can read back in the notes, and sometimes you can just follow up on your own, or if you're confused about what the sticky note means, definitely just grab me or Janet, and we can look back at the chart and ask the appropriate questions. So the last thing that I wanted to touch on quickly is referrals and collaborations, some things that you might see based on what clinic you're working at. Like I said, because of our connection with Centura Health, we want to utilize either the Centura Health Physicians Group network of doctors and primary care providers, or the Colorado Health Neighborhoods is a kind of a medical home model for across Colorado that is enrolling various providers and healthcare professionals to create an entire health neighborhood for people. So check Colorado Health Neighborhoods has its own website, so you can look into that and kind of see what we're doing there to help clients, help patients all over Colorado. But HealthSET will be utilizing those two networks to provide new doctor referrals for our clients if they need somebody. And like I said earlier, if they do not have a convenient option for a CHPG or CHN doctor, by all means, then we'll utilize what works best for the client. But we want to think first of Centura due to our sponsorship and our support from them. And then Centura Health Links, second on the list there. We are going to be working with Links for the next year at least, doing benefits checkups. And the benefits checkup is a standardized benefits assessment that checks both public and private benefits of over like 2,000 benefits that our clients might be eligible for and not know about. So our Links counselors that we share an office with actually will be coming to each of our clinics on a rotating basis. They'll be coming every 4 months to each site and doing a benefits checkup event. So I'll keep everyone up to date on when those are happening so that we can promote those and encourage our clients to come immediately after our clinics to get a benefits checkup from Links. And then the last thing on this list, Jefferson Center for Mental Health, their Senior Reach program is working with us on a grant we're collaborating on for the Jefferson County buildings, which are Marcella Manor and Eaton Senior Communities, and then Highland, our new clinic in Wheat Ridge. We are working with Senior Reach, and they can provide one-on-one counseling for mental and behavioral health for our clients. As part of the grant, it's free for the client for 10 sessions. So we will be screening people for depression at those sites in Jefferson County and then making the appropriate referral to Senior Reach on an as-needed basis. And lastly, I want to just say thank you to everyone that's volunteered this past year. As you can see, we have over 5,000 volunteer hours from all of you guys, so we couldn't do the great work that we do for the low-income elderly across the Denver metro area without you. So thank you so much. And if you ever have a story or a impactful moment at clinic or with a client that you think could really illustrate the great work we're doing out there, by all means shoot either me or Lori an email with that information. We're always collecting those success stories and those great moments out there at clinic. So thank you very much.